of questions from you. So you may type your questions in chat box, and I want to let you know that we will address as many as we can in the time we have today. And I welcome and request our NBMS National Webinar Coordinator, Professor Dr. Somashekar, to start this session. Welcome, sir. Over to you.
Thank you very much, Navneet Singh ji. Dear trainees, welcome. So, in our second series of the thoracic oncology, which would now go for next 1 month, and then again we revisit after head and neck next month. Come back to April, May month again. Of specialist in thoracic onco. First topic is on approach to solitary pulmonary nodule. This is a very, very important topic. You will get caught up in the tables afternoon, not just theory, and you'll also get caught up in the specimen, CT scan, X-ray discussions, and also theory. This is going to be covered by Prasanth. And then we have screening in lung cancer. We thought that India is not a country, even breast cancer and cervical cancer, we couldn't optimize our screening. Where does lung come? But gone are those days. Now with very aggressive pulmonologist, interventional pulmonologist, lot of awareness, and all this, smoking, anti-smoking campaign coming up, screening in lung cancer is coming in big way. And since the minimal access surgery VATS in India has taken a huge leap, there is a meaning where the whole treatment is cut short, quality of life, minimal access has come, and outcomes and results are totally different. So, approach to solitary pulmonary nodule, and then Sarvana is going to speak on that, and screening on lung cancer, Prasanth is going to speak. So, at the end of it, trainees, put your questions in chat box and Q&A. Both of them are very, very busy and surgeons, but yet they took the time for you. Optimize it. Take my word, at least during our surgical onco, just because I was in a unit where my teacher used to do, the only one who used to do thoracic onco, I got exposed. Otherwise, most of you, 99% would never ever get exposed. Please use this opportunity. Very exciting field, fantastic upcoming, very challenging, very rewarding. And then two great thoracic onco people who have got surgically onco trained, and then doing it, you are get to learn from two experts. So optimize this. Thank you very much, Prasanth and Sarvanan. And Sarvanan, over to you. Welcome.
Yeah, I'd like to thank the NB and the organizers, Dr. Somashekar, and all the students to get up as early as 7:30 in the morning for this lecture. So I'll start. Is my first slide visible?
Yeah, very clear.
Yeah. So I'll be talking about approach to solitary pulmonary nodule, and this will be mainly on the perspective of the surgical aspect. What a DNB surgical oncology student has to know, and it will be in that perspective, and a little touch upon what is happening in the world currently right now. So what is the definition of a solitary pulmonary nodule? This will be asked in your table. So a solitary pulmonary nodule is a discrete, well-marginated opacity seen in the scan. No longer we define this according to an X-ray radiographic image. Most of it has now changed to a computerized tomography, which is a CT scan. These lesions are supposed to be less than or equal to 3 centimeters in size. They should be completely surrounded on all sides by lung parenchyma, and it should not touch the hilum or the mediastinum, and should not be associated with pleural effusion, lymphadenopathy, or atelectasis. So all these criteria should be satisfied to define a lesion in the lung as a solitary pulmonary nodule. So any lesion more than 3 centimeters in size or that is not fitting into this criteria is called a mass, or some other radiological terminology will be applied. But this is the standard definition. So why is it becoming more and more important is, in the next talk, Dr. Prasanth will speak to you about screening. We are seeing more and more of lesions in the lungs which require evaluation and management. And this is a classification of solitary pulmonary nodules. Now we classify them as solid lesions and subsolid lesions. This is the terminology that you need to remember. And in subsolid lesions, you divide them into two types. The part solid lesions, in lesions which have a small component of solid component, and purely ground glass opacity lesions, which are pure ground glass lesions. So there are a lot of differential diagnoses of solitary pulmonary nodules. Most predominantly all of these lesions are benign. So that is why it is very important for us to identify We should not intervene in persons where the lesion is benign. Neither should we miss patients who are, in the best portion of their time, because if you diagnose a patient with stage 1 or in situ lung cancer, their survival rates are more than 96%. So why do we need to manage? Screening is getting more and more common. This COVID pandemic has actually reduced the threshold for CT scan among physicians, both chest physicians and general physicians in the community. And so we are getting more and more of these lesions. And we need to identify those lesions which need to be removed or taken care of. Most lesions are benign. So it takes very good judgment from the clinician to actually select the patients needed for treatment. If we can identify malignancy, cure rates are more than 95% in these cases. So the WHO classification, which was modified recently, has told that you should avoid this terminology called bronchoalveolar carcinoma. So this is a trick question which will come in your exams, in your viva. So they will ask you what is BAC. So BAC is a terminology which was used previously to determine lesions which were malignancy proven after you remove the specimen for a ground glass opacity or a part solid kind of lesion. So you can see over here the lesions. You can see a small faded non-solid component lesion, a ground glass opacity. This lesion is an in situ lesion, and this lesion is a minimally invasive adenocarcinoma lesion, and this is an invasive adenocarcinoma lesion where you have a small component of invasion and hence the solid component. So even though these are in situ and minimally invasive lesions, these are considered malignancy, similar to what we talk in breast like DCIS or in the CIN classification of cervical cancer. So kindly avoid using the term bronchoalveolar carcinoma. So these are in situ, minimally invasive and invasive adenocarcinomas, and they are increasing day by day in current practice. So what is our goal in management of solitary pulmonary nodules? Our goal is to define whether this is a benign lesion or a malignancy lesion. So this has two main, factors. So we need to identify the risk stratification, and generally the probability of malignancy depends on these three features. So the low risk, a person who is of young age, no or less smoking, no prior history of cancers, small size nodules, regular margins in the lesions, non-upper lobe lesions. These are having a very low risk, potential for malignancy. Whereas you can see the high risk, the classic older patients, heavy smokers, prior cancer, large lesions, irregular margins, and upper lobe locations are more. And when you have an intermediate feature, which is a combination of both low risk and high risk, the probability is intermediate. So when we talk about risk factors that are associated with malignancy, before we go into evaluation of SPNs, there are two things which we need to identify. One is the patient factor, which I mentioned, heavy smoking, exposure to radon, asbestos, uranium, family history, old age. You will be surprised to know that female sex has a higher propensity for having solitary pulmonary nodules, which are malignant compared to males. Race is important because Hispanics and blacks and Asian communities have a higher incidence of malignancy compared to the Western population. And then you have the lesion factors like margins, components, which I'll delve into detail in the next. If you have more than 5 lesions and the patient is not a case of an osteosarcoma or a metastasis, more number of lesions mean it's going to be benign. Less number of lesions is pointing towards malignancy. So when you want to differentiate between benign and malignant in the CT scan, you should remember this one chart. So you can classify, just like in breast, you classify different types of calcification within the lung nodule. It can be diffuse, it can be central, it can be laminated, or it can be popcorn. So you can see in India, we have so many benign lesions that everyone who's getting a CT scan and there's a lesion, they'll panic and come to you telling, I'm very scared. Can it be lung cancer? Can you remove? So when you have calcifications which are like this, a bullseye classification like seen over here, or a diffuse completely calcified lesion, or a laminated lesion like this, most of these are healed granulomas or granulomas, which is very common in our society, especially in post-TB. Then you have the other types of classifications, common, CT question. This kind of popcorn classification is a classical picture of hamartoma, I've seen many patients, being suggested surgery for this lesion. However, this is just a benign lesion. Cancers also can have calcification, just like in DCIS you have punctate classifications. Here, scattered punctate classifications are classical of carcinoid tumors, and eccentric punctate calcifications can be seen in adenocarcinoma. So, how about margins? So, if you have a lesion which has smooth margins, lobulated margins, most probably they're going to be benign compared to this, stellate or spiculated margin, which pulls or drags the pleural surface also into the lesion. So this is classical of malignancy. Nodule size is very important. After analyzing around 2000 screening CT scans, if a lesion is bigger in size, the probability of malignancy is higher. So this, in a high risk population, when they screened a lot of patients, they found that the lesion size, when it is above 4 millimeters, above 8 millimeters in size, it is very high. And most of the guidelines which determine how we manage these lesions are based on nodule size. What about the shape? So we normally, as surgical oncologists, we are very used to looking at the radiology image in the axial dimension, and just you can see the image on the left, which is an axial image. You would probably think the chance of it being malignancy is high, but then when you use a coronal image, you can immediately find that it's polypoidal or it's polygonal in shape. So in Japan, where they do a lot of screening for lung cancer, they have found that this three-dimensional shape of the lesion also determines whether the lesion is malignant or benign. So a polygonal shape is more benign, whereas a star-like shape is malignancy. So all these things are important. What about the solid component? I mentioned that you have part solid, subsolid, pure GGO, and you have complete solid. It is very well known that more amount of solid features within the scan, the more chance of malignancy it has. Mind you, all these are high resolution, thin cut CT scans. Actually, you don't need contrast for taking these CT scans. These are thin cuts, meaning 5 millimeter or ideally 1 millimeter cuts of the CT scan image in the lung window. So you can see the malignancy risk is 18% in a pure ground glass opacity in a screen detected lesion, whereas in a part solid, the malignancy risk increases to 63%. Just because a lesion is solid doesn't mean the malignancy risk is going to be the highest. You can see over here that if a lesion on screening CT scan or a CT scan which is done and an incidentally detected solitary pulmonary nodule has come to you, if it's a solid lesion, only 7% of these lesions are malignant, because predominantly these solid lesions are benign lesions. So this is why we need to know what is these, how do you follow up these lesions. You can see a lesion over here on the left hand side. Here you can see a small GGO which is seen in a streak of the pulmonary artery over here. Whereas when you followed up this patient, same patient, after 6 months, that lesion has gone away. So it's very important to identify that solid or subsolid lesions which are small in size need to be followed up. And the growth pattern is very important. However, when you see a lesion which is persistent or which is growing in this follow-up CT scans, these are lesions which we need to identify and take notice and treat them. Another commonly, misjudged lesion is these periphyseal lesions. Predominantly, more than 99% of periphyseal, that is lesions which are abutting the fissure, are usually benign. 99%. Only 1% of them are malignant. Of course, we do see periphyseal malignancy also, but predominantly these are benign. So the growth rate of the lesions is the most important factor among all the characteristics which determine whether a lesion is malignancy or not. And it's also going to determine how we are going to follow up these patients. So even if the lesion is malignancy, if the lesion is subsolid, then the doubling time is more than 400 days for a subsolid lesion. Whereas for solid lesion, the doubling time is around 330 to 400 days. So what this means is that even though early malignancy, sometimes are present for years together, and you have to follow up these lesions for years together. So that's why, most of the management of solitary pulmonary nodules are focused on these guidelines. These are the most common guidelines. The Fleischner Society and the Langrads are the most popular. These guidelines determine, how we are going to follow up these solitary pulmonary nodules when you identify them on a CT scan and deal with them. There are key differences. What you have to remember as a student is to know that, the 6 millimeter, any lesion which is less than 6 millimeters, usually, the follow-up becomes optional. And the cutoff is more than 6 centimeters, you have to follow them up vigilantly. And the time of follow-up varies depending on the guidelines. I'll just focus on Fleischner for now, because it gets confusing as you go into each of the thing. But more than 6 millimeters nodules, you have to usually check up. And if a lesion is more than 8 millimeter in a person who is having a high risk of developing lung cancer, like I mentioned before, you need to consider all the guidelines suggest that you need to get a PET CT scan or a biopsy from that particular lesion. And for the duration of follow-up in Fleischner Society, I'll mention so this is what we do. Any lesion less than 6 millimeters in size, you divide them into low risk or high risk, like I mentioned below, and then you do a CT scan, which is either optional or becomes mandatory at 12 months or 6 to 12 months or 3 to 6 months, depending on the size of the lesion. So mind you, if a lesion is solid and it has been stable for 2 years, we follow them up only up to 2 years for Fleischner Society guidelines. However, when the lesion is subsolid, because the doubling time is very, very slow, we have to follow up these lesions for up to 5 years. And you can see over here, similarly, there is a follow-up strategy which is based on the features on the CT scan. So if it is less than 6 millimeters, no follow-up is indicated if it is pure ground glass. Whereas if it is more than 6 millimeters, then you have to do at 6 to 12 month intervals for a period of 3 to 5 years. So depending on this, we follow up these patients and we closely watch the lesions. Another question they may ask you is, how do you measure? It is easy. So you take the longest dimension and the shortest dimension, you add both and divide by 2, that gives the famous. So what is this 6 millimeter when we are talking about on the Fleischner Society guidelines or any guidelines? So we measure the longest dimension, shortest dimension, divide by 2, and that is your final measurement. If there's a part solid nodule, you have to mention both the solid component dimension as well as the non-solid component dimension, the subsolid dimension. And if it's a purely solid nodule, similarly, like I mentioned, just like how you calculate a pure GGO, you measure the subsolid lesion also. So whom do we intervene? So, and how do we intervene? So I mentioned, like, the Fleischner Society guidelines classically mention that, it gives you a direction in whom you should intervene also. And depending on the risk stratification, you need to intervene in these patients. Now, how do we intervene? Generally, there are two methods. A CT guided method, where you take the patient to a CT scan and under CT guidance, you localize the lesion, or you go at the lesion by a endobronchial method. So CT guided lesion is primarily very, very important in non-palpable lesions, because deep-seated lesions very difficult to palpate, especially when you're thinking of a diagnostic procedure and we are going to do with VATS or robotic. We can't palpate these lesions, so we must be able to identify. So these are the primarily most important ways in which we do it. There's an option called a hook wire, where we insert a hook which is J-shaped into the lesion in the CT scan room, and then shift them to the OT and then remove the hook wire under image guidance like C-arm if required. Second, like we use in breast cancer, we put a fiducial by CT guidance at the center of the lesion, and then go and take it under C-arm guidance in the surgery operation theater. Or we use a dye, where we inject very small quantities of methylene blue, and then you go into the theater and remove that portion of the lung. However, this is being drastically shifted to endobronchial methods, because when you use a CT guided method, the chance of pneumothorax is high, especially in patients with emphysema, classic patients with upper lobe lesions. A lot of them develop pneumothorax following surgery, following CT guided procedures. And so you have these methods in using the bronchoscope, like the radial probe EBUS, where you insert a bronchoscope which has a radial probe within it, and it goes and identifies in the peripheral bronchus the lesion, and you can actually locate, insert a catheter at that particular point and take a biopsy from that particular lesion. The other methods are the electromagnetic, which will come in detail later, and the robotic navigational bronchoscopy. So what is this navigational bronchoscopy? Navigational bronchoscopy is a method in which we use the magnetic, we keep a plate at the base of the patient called a magnetic plate, and then we keep markers on the body. And what happens is we feed the CT scan into the machine, and the CT scan gives us a pathway in which we can, guide the bronchoscope to that particular lesion. Because mind you, you cannot see, you're going very much peripheral. And as you go, because you have these magnetic markers on the patient and which are linked to the bronchoscope image, what happens is side by side, it gives you a pathway to take a biopsy. So this is actually a blind biopsy where you cannot see where you're going to, puncture and get a biopsy. It is navigated by feeding the image into the scan, and the magnetic, the navigation takes the, guides the bronchoscopist to direct his needle direction towards that particular direction. This is being rapidly changed in the Western society by the new entrance of robotic bronchoscopy, where the entire navigation is done using a joystick method or an automatic method by the bronchoscopist. You just insert a shape sensing catheter into the patient via a bronchoscope under general anesthesia, and the catheter is taken on its own to that particular lesion, because the lesion's CT scan has been fed up into the system. It's very difficult when you're doing navigational bronchoscopy, like I mentioned previously, because the bronchoscopist is blind and he has to go front, back, etc., etc. And whereas here it's easy, like a joystick, you just go and you click left button, right button, and go towards the lesion to get the biopsy. So what happens when you identify, okay, this is the patient that we need to intervene, and we have to take a decision on removing that particular lesion? There are various methods of treatment of solitary pulmonary nodules. So initially I will mention the surgical methods. We have a wire localization method for removal, like I mentioned before, a dye localization method, and an endobronchial localization method to remove the lung lesion. So this is the most common procedure which is done for a patient with a path solid or a small lesion. It's actually a wedge resection, because most often than not, it's very difficult to get a biopsy by CT guided methods or even bronchoscopic methods. I have had so many times being referred a patient with the diagnosis of inconclusivity by CT guided FNAC, because these lesions are very small. It's very difficult for the pathologist to identify malignancy in these lesions. So wedge resection actually is the most common procedure which is done for a very suspicious solitary pulmonary nodule. It can be done by VATS, which is most commonly done. How do you identify these lesions? When you go inside, it's very difficult. And so one of the most, popular ways that even I use in a thing is, we go with the bronchoscope and we inject very small quantities of indocyanine green under the navigational bronchoscopy or under cone beam CT guidance. If the lesion is within 24 millimeters from the surface of the lung parenchyma, this one works, because if it's too deep, the camera which you use cannot identify the indocyanine green at the surface of the lung parenchyma. So you have to make sure that the lesion is little close to the pleural surface, and then after injecting this via the bronchoscope, it stays inside for about 6 hours. And once you do this, you can go inside and you can see the image where it will be showing a green picture will come up, and you can take out that particular lesion out and remove the lesion. So it's very important to identify that when the lung is expanded, some lesions are very deep. So just this 24 millimeter criteria is not on the CT scan, but it's actually on the deflated lung parenchyma image. So what guidelines I usually use is, if the lesion is around 5 millimeters to 2 centimeters from the surface. When you deflate the lungs, it comes to the surface. So in these lesions, you can use indocyanine green, whereas in all other lesions, it's better to use methylene blue dye because you won't be able to see the ICG on the surface of the lung parenchyma. So this is how it is done. You have these thin bronchoscopes now, bronchoscopes which can go peripheral into the peripheral 1/3 of the lung, and it's amazing that you can actually go and then inject the dye from your CT scan. If you're able to identify, okay, this is the particular segment where this lesion is, you can actually go using these thin bronchoscopes into that particular segmental bronchus and inject ICG, and the entire segmental zone will be taking up ICG on your near infrared image screen, and you can remove that entire portion of the lung for biopsy. So this is how it looks. The entire segmental zone has been, because we can't go very peripheral, we inject ICG dye into that subsegmental bronchus, and the entire zone becomes green with the most at the center of the lesion. So you can actually remove that particular lesion and send it for biopsy. So this is how it looks. Once you take it out, you can check after you remove the specimen that you've removed the right particular specimen, and you mark this and send for your frozen section, because most often on frozen section, if it is confirmed as malignancy and the lesions are more than 2 centimeters in size, we'll be proceeding to a lobectomy. There are now single stage procedures which can be done using robotic bronchoscopy. Like I mentioned, you actually go inside and you place a marker or a dye exactly at the vicinity of the lesion, and in the same sitting you do a VATS or a robotic procedure and remove the lung nodule. So what I mentioned earlier was a stage procedure. You do it in a bronchoscopy suit, shift the patient to a OT, and then do the procedure. But now it's becoming more and more common to have a cone beam CT within the OR, which can actually guide us in placing the exact location of the nodule and then doing the surgery in the same operation procedure. Why all this is important? Because survival in early lung cancer, especially in stage 1 and in situ, is more than 96%. And with more and more lesions which are coming up, it's very essential that we identify those lesions which we need to intervene and take out and get a diagnosis from. With that, I think this is a brief lecture, and thanks for listening. I think it will give a small guidance on how you need to identify lesions which are suspicious and then take them up for intervention. Prasanth?
Thank you, Dr. Sarvana. I think we will take the questions at the end of both the sessions. So we have a lot of questions already, so we will take them. In the interest of time, we will, just a second. So for the next 15-20 minutes or so, I will be speaking about the screening for lung cancer and what are the challenges that we face, and what is the status, what are the optimal tools that we have as of today. Okay. So now coming to screening for lung cancer, as Dr. Sarvana has rightly mentioned, identifying these nodules at an early stage, okay, we're looking at reducing mortality. Remember, screening is always to reduce mortality. Okay, so then now, for the sake of residents, it is very important to know the Wilson and the Jugner's principles of screening. For any screening program to be successful, these are the principles that should be mandatorily followed. So, does lung cancer screening merit from all these principles? We will see in the next few slides. So, it should be an important health problem, and we should know the complete natural history of the disease. It means, when I say natural history, from etiological factors to, from the latent period to calling it a declared disease. And we should also have an established treatment when you diagnose them early. And this treatment should actually improve outcomes. Okay. And moreover, you should also have a suitable test that is acceptable to the population, where also at the same time it should be easily replicable. You shouldn't be looking at things which actually have some fancy test and they cannot be replicable across, then the screening program will never be successful. Okay, and more importantly, you should have the facilities to diagnose and treat those particular lesions that you pick up on screening. So these are general principles of screening. Okay, and mind you, the most important thing, it is never a one-time event. So the case finding should be a continuous process, otherwise the project will fall. So with these principles of screening, I would go about what do we have in lung cancer, whether can we screen, not screen, what are the tools available, what were used, and what is the standard of care as of today. So the first question, is it a major health problem? Do we really need to screen lung cancer? What is the issue? Yes. As you can see, lung cancer in both sexes, this is the Globocon data, stands one of the second most common malignancy across all malignancies in both sexes in terms of incidence, that is new cases diagnosed, as well as it stands first causing mortality. The main reason is being because most of these, around 90% of these, are picked at an advanced stage. So, do we know the natural history? Yes, we very well know the natural history. And mind you, we all know prevention is better than screening in lung cancer. If you can, because you have known etiological factors, and 90% of them are still today associated with smoking. So, in both the sexes. In India, the relative risk is about 2.45, whereas the passive smoking relative risk is about 1.16. And mind you, it is not only active smoking, but also some form of smoke exposure, as in the environmental smoking, which also includes the coal dust, which also includes the pollution, which also includes the passive smoking. And we know the natural history too, that if you have a lesion that is picked up in stage 1A1, then the chances of survival by treating them would be about 92%, whereas none of the 4Bs would actually survive more than 5 years. So you know the natural history well for these patients, and henceforth there is a justifiable reason why we should be screening lung cancer. So is there any real benefit, or is it just another screening? So yes, it helps in early detection. So any screening program is meant to detect these cancers early, and 80% of them are in early stage once you start screening. So that's the biggest advantage. And if not screened, for example, if you don't screen, and 70% of them, whatever you see present at an advanced stage, which is not the goal. So, and mind you, we can get away with smaller surgical resections. As Dr. Sarvana mentioned, depending upon the different types of nodules. So, the approach to all of these nodules, we could actually get different kinds of nodules and manage them accordingly with smaller surgical resections. Now there is adequate data, to say that smaller resections like segmentectomies can be the standard of care for lesions up to 2 centimeters. And mind you, it also adds a positive impact on smoking cessation rates. So this has been proven in one of the largest NLST trial. They did a sub-analysis and they found that it also has an impact among the moment you say, okay, you're going to do this, then there is an impact on the smoking cessation rates. And we all know that it leads to better survival. So do we have a suitable test? Yes. And should we be finding better? Yes. So any screening tool that you use for across cancers should have a suitable test, but it also comes with some potential risk, which we'll be discussing in the next few slides. So the initial screening tests that were used were the chest X-ray and the sputum cytology. They are no longer recommended, but it is interesting to know what they did and how the screening actually started off with these two. So initially, the entire screening program started in 1940s using a chest radiograph and sputum cytology. So one of the largest studies was the Mayo Lung Project, where there was an increase despite it increase in 5-year survival, but it did not translate to reduction in lung cancer mortality. Another study similarly in Czech also failed to show. And one of the largest study that you all should know is the PLCO trial, which actually across 10 sites, in about 150 odd men and women together, screened using the chest X-ray. So one chest X-ray at baseline and for 3 consecutive years. So with 13 years of follow-up, there was no significant difference in lung cancer mortality was observed. And it was actually intended for a 20-year that which was supposed to be done in 2015. But by the time the NLST trial results were out, and then they showed the authors did not analyze because they felt that they might not make much of a difference if it is not shown in 13 years. So with this, the era of chest X-ray and sputum cytology went into latency, and then came the trials which looked at CT. So the moment when you say CT, you're all worried about the history, the possibility of radiation exposure. So that is why they introduced the concept of low-dose CT. This is one of the largest trials published, and mind you, their inclusion criteria is very strict. So whenever, this is for the sake of residents, whenever you actually look at any trial for that matter, please keep in mind that what inclusion criteria was actually used. And you can actually apply whatever the results of that trial only for that inclusion criteria, and it cannot be generalized. Okay, so they had individuals between 55 to 75, 74 with 30 pack years. That's a huge amount. So remember this, because in India, we don't have so much amount of intensity of smoking. The current smokers or who have quit less than 15 years, and they did an annual screening for 3 years with an LDCT, and the follow-up was for 6.5 years. The best part of the trial was there was definite reduction in lung cancer mortality, 20% reduction between the screen group versus the no screen group. And there was actually a true shift between detecting early lesions in the CT scan group. And interestingly, they also found that all-cause mortality, from all other causes mortality also, there was a significant 7% reduction. But however, 18.5% of the cancers represented an overdiagnosis. So we'll come to what is exactly overdiagnosis later in the next few slides. So this is what the lung cancer mortality reduction by 20% and the all-cause mortality around 6.7 to 7% in the NLST. So with the advent of this trial, with the results of this trial, the low-dose CT became the standard of care for screening. But there are challenges because, as I said, it is strictly confined to that particular group. Okay. Low-dose CT is an appealing technology because it uses very minimal dose of radiation. The images are not very sharp, but the sensitivity and specificity for detecting of a lung nodules are excellent. Okay, so the US Task Force evaluation also says that annual screening with LDCT is of moderate net benefit in asymptomatic patients at high risk for lung cancer, and the total cumulative exposure and since years since quitting. So then came the Nelson trial, which also looked up between the same age group, but for smoking for more than 10 per day for 30 years or 15 per day for 25 years. This had a slightly different inclusion criteria. And this was a 10-year follow-up, and CT was done at 1, 2, 4, and 6.5 years. So 50% of the cancers diagnosed in screening arm were early stage, and 70% in control were the advanced stage. So when it came to reduction in mortality, there is 26% reduction for men and 39% reduction for women compared to the control. So this is a significant reduction in mortality by screening. And is it really needed to do more trials? Yes. So there are 7 other randomized control trials which have actually looked at the LDCT, but various of them have been used for different. But NLST and Nelson were the 2 largest randomized control trials which have actually shown. So NLST, to conclude, to prevent 1 lung cancer death, 323 with 3 rounds of annual screening compared to chest radiography. Remind you, chest radiography was the standard arm. Most of the studies that were actually done is LDCT versus no screening. But the NLST trial actually had a chest radiography because till that time, chest radiography was considered the standard of care for screening. So Nelson also found a reduction, and the number need to prevent 1 lung cancer death of 130 over 10 years of follow-up with 4 rounds of screening with intervals compared with no screening for current or former smokers between 50 to 74 years. So this is the gross results of the NLST and the Nelson trial. So there were various other trials that were conducted using the NLST. This is for the sake of residents, and there is a wonderful table which actually puts up all the trials which are there for screening lung cancer with different things, the most important being the NLST and the Nelson trial. So, don't we have any limitations? Can't we use these for all patients? So, I will also be touching upon a perspective with an Indian perspective too. So, most of this, one of the major problem is to have abnormal findings. You incidentally diagnose some other abnormal findings, and the most abnormal findings that were diagnosed was having, benign or inconsequential in about 97%. And some of them had emphysemas, coronary calcifications, which might not have actually caused, but then once you pick up a finding, it actually leads to patient apprehension, and then you end up treating these patients which otherwise wouldn't have got treated. So that is one of the major problems. And radiation exposure, yes, whatever said and done, the amount of radiation exposure, if you see after 10 years of screening, was 13 millisieverts for women and 9.3 millisieverts for men. And this is quite significant. Though compared to the regular CTs, it is much less. But when it comes, the amount of radiation exposure is still stands significant. And for every 108 lung cancers discovered by screening, one major cancer would be induced by radiation, which is still significant. So, overdiagnosis. What do you mean by overdiagnosis? Overdiagnosis, when you would pick up these lesions which otherwise in patient's lifetime wouldn't have caused much harm. And across studies, these lesions were about 13 to 27% caused overdiagnosis by screening. But however, the evidence is not very strong because it is very difficult to prove or disprove whether the overdiagnosis is a true percentage, because natural history or the biology of a disease varies from person to person. But, and more importantly, patient distress. As I said, picking up of unnecessary nodules, possibility of an overdiagnosis, false positives. So there is definitely a patient distress. So once you screen till you have the result, patient has short-term psychological distress, worry, and quality of life issues too. And the incidence of and the complications related to achieving a diagnosis. The possibilities of once you have a nodule, you need to diagnose it, you need to pick it up by histopathology. So the complications associated were also something which are some of the major limitations of screening. Okay, so there are some solutions. Okay, so to actually reduce overdiagnosis, the Granin et al. Suggests that, as Dr. Sarvana also mentioned, the progression is something that which is very, very important. So when there is a clear evidence of progression in the form of growth or transition from non-solid to part-solid nodules before recommending a biopsy or surgical resection. So you need to look at that. So the growth phase. So this is similar once you pick up a nodule and then you get into the approach to the solitary nodule, how the solitary nodule program. And technology is also changing now. And, the lung cancer can be done with as little as 0.1 millisieverts with the new generation dual CT slot. So the radiation exposure would be definitely lesser, and this would lead to less radiation exposure. So as I said, the pitfalls, 20 to 50% of them we find nodules, inconspicuous, and screening should not be recommended beyond the guidelines or in patients with comorbid or less life expectancy. And, it unnecessarily creates anxiety among the. So in the new era, as of today, so considering all the pitfalls of lung cancer screening using an LDCT, so there is a role of biomarkers that is actually coming up. So we have a lot of biomarkers, but unfortunately, none of these biomarkers as of today are the standard of care, and they need to be proven in large randomized controlled trials. So these are some of the biomarkers that have been checked. I have specifically mentioned for two biomarkers which have robust studies that early lung cancers can be detected. So you have DNA based, which can be ctDNA or a cell-free DNA. You have RNA based, wherein you have microRNAs, miRNAs, piRNAs, transfer RNAs. There are so many variants of RNAs. The protein based markers, which are a combination of antigens as well as autoantibodies. They come out the commonly used antigens where CEA was commonly used, and CIFRA 21-1 was also an autoantibody which is actually used even for early detection of lung cancer. So among all those, the early CDT lung, it's a 7 antibody test which has been very well validated, and as of now today holds high, probably recommended for biomarker screening, but however, it needs to be done in randomized controlled trials. And you have immune serum conversions as biomarkers, or the circulating tumor cells and methylation based biomarkers. So lung epi-check is one which has a very high sensitivity and specificity among all others, and these are being tried and tested more and more in adjunct in comparison with LDCT as of now, so that tomorrow in future the LDCT can be omitted. So what are the challenges in India do we face? As I said, the smoking prevalence is not that high to actually, have patients, and we may not have the exact etiological factors that may translate to lung cancer in India. So in India, we do see a lot of, especially not only in India, but in the entire Asian countries, about 30 to 40% of them are women and who are never smokers. So it is still not clear. There is a lot of hypothesis towards environmental smoke, passive smoking among these individuals causing lung cancer, but it is still not very clear. So these group of patients can get missed out, and which is actually a good amount, that is about 30 to 40%. Okay, the other major problem, you screen, you're going to pick up nodules. There's high prevalence of tuberculosis and other granulomatous conditions, which results in a very high false positive. So, this actually dilutes LDCT as a valid screening tool for, once your false positive rates go up, your burden on the system increases and it may not be possible to effectively utilize. Then you have lack of resources for an organized screening program. Is it possible to have a program? As of today, it is challenging because the number of centers that are available, to diagnose nodules and to put needles into the nodules and treat them accordingly, yes, are still far limited. So there is a definite linkers. So changing etiological patterns, which will not fit, as I said, will not fit into any of the proven criteria, either NLST or the Nelson's criteria. And unfortunately, there is no standardized screening tool for low-risk population. So residents could actually look up at various models because, these are some of the models that have been stratified for categorizing them into high risk or low risk. And if you see the low risk, we don't have. Only in the high risk, we have standardized tools. So we really need to look at something for the low risk. And probably that is where the role of biomarkers would play an important role. Okay, so this is an interesting model which I felt that, they have divided them into different categories. And then based on the categories, when you should consider. So this is a Canadian model. For normal finding, benign calcification, consider biennial screening, low risk of malignancy, annual screening, moderate risk, rescreen in 3 months, no growth, consider otherwise. So these are different models for, once you pick up a solitary pulmonary nodule. So this is another similar criteria, which I think Sarvana has already discussed, so I'm not getting into this in detail. So to conclude, lung cancer screening with low-dose CT in high smokers can reduce mortality by about 20%. Currently, there is no new treatment modality that can reduce death from lung cancer to this extent. So screening should be employed in the high-risk population. Lung cancer prediction tools to identify people at high risk is a major advance, and accurate lung nodule malignancy calculators are there to actually reduce the number of people who actually need follow-up scans or, further interventions. So lung cancer screening is a multifaceted process and involving much more than, simply just ordering a scan. Your work doesn't get over by just simply ordering a scan. Ask for an LDCT only after understanding the pros and cons in screening lung cancer. And thank you, and we would be happy to take a few questions from any questions from the chat box.
Prashant, I think the first question, excellent talk.
Yes.
First question is regarding smoking. So what is the, so I think you can answer the question best. What is the criteria for smoking when you call somebody who is a fit candidate for a screening program, if at all there is a screening program?
Yeah. So the studies what have described is completely different. But the GAD survey in India, all residents should read what the GAD survey is all about in India, especially. The incidence of smoking is much less and is never of that will fit into the criteria. You have 30 pack years of smoking, and also in the NLST criteria, and they have taken current as well as fast smokers within less than 15 years. But if you see the Nelson's criteria, it is 10 per day for 30 years. In India, the problem is we don't have such heavy smokers. Okay, and the pattern of smoking is also completely different. If you come to the rural world, it is more of BDs, which is not equivalent to that of the smoking cigarettes, or the cigars for that matter. So that is why this makes it challenging for us to actually quantify. So for India, I think we need to have something which is completely different from what the category of smoking is. So there is very limited data as of today for considering the smoking in India in terms of pack years and then its risk, or for that matter screening too.
I think for the exam purpose, you can just go with the NLST criteria. It's a safe answer to give. So when they say patient is a high risk, based on the smoking status, it's usually more than 30 pack years. 30 pack years means 10 cigarettes per day for 30 years. So it's safe to answer that in the exams. If somebody asks you about BDs, there are 25 to 27 BDs per pack in India. So that would be the ideal thing that you should be mentioning. Okay, the next question is, in a 1 centimeter lesion, greater than 1 centimeter lesion, would you prefer a biopsy in every case, or if not, whether to send for intraoperative frozen section for confirmation? See, like Dr. Prasanth also mentioned, the problem with lung cancer screening is, over detection and over treatment of these lesions. So ideally, a patient who's having a very suspicious lesion, which is more than 8 millimeters in size, like we mentioned, anything more than 8, usually, in a high risk individual should go for a PET scan to further identify whether the patient's lesion is suspicious or not. And when do we biopsy? Biopsy is usually, it's very difficult to get a CT guided biopsy for a patient with a lesion of 1 centimeter in size. So when you serially so normally what we do is, when we see a lesion which is on PET CT scan, it's very low uptake. So this is also a very important question in your exams is, most of these screen detected malignancies have a very low PET CT uptake. So when you do a PET CT in a patient with minimally invasive adenocarcinoma or early adenocarcinoma, their SUV uptake will be less than 4. So these patients will have a low, SUV uptake, and so we are going to follow up these lesions. In serial follow-up, if you see that lesion is growing, a sub-centimeter lesion which was non-FDG avid is growing, that is an indication for a biopsy. Now, biopsy depends. If the patient is not emphysematous and if your intervention radiologist is very good, yes, go for a CT guided biopsy. In certain centers, totally it has been replaced by endobronchial biopsy. If you have the facilities, then endobronchial biopsy also would be an option. But by far, in a growing lesion, most of these patients come for surgery, and what we do is normally we do a wedge resection. We confirm whether it's malignancy or not, and then proceed with a definitive management if it is malignant.
Yeah. Yes, Sarvana. So there are a few more questions in the chat box. Sarvana, meanwhile, as I answer the other questions, they wanted to show the size table slide again. So if you can do that, meanwhile, I'll just answer the few questions. Yeah, you can share and then just show that.
Mr.
Okay.
Navneet, just allow me to share.
So meanwhile, till that comes up, why is MRI not a good modality for screening? So MRI as such is not an accepted or modality for diagnosis when it comes. The problem is the time that it takes. So when you have a screening tool and it is not practically feasible or replicable, remember, as I said, the principles of screening. Okay, a screening tool should be replicable, should be easy, should not cause, should be done.
Now, biopsy depends. If the patient is not emphysematous and if your intervention radiologist is very good, yes, go for a CT guided biopsy. In certain centers, totally it has been replaced by endobronchial biopsy. If you have the facilities, then endobronchial biopsy also would be an option. But by far, in a growing lesion, most of these patients come for surgery, and what we do is normally we do a wedge resection. We confirm whether it's malignancy or not, and then proceed with a definitive management if it is malignant.
Yeah. Yes, Sarvana. So there are a few more questions in the chat box. Sarvana, meanwhile, as I answer the other questions, they wanted to show the size table slide again. So if you can do that, meanwhile, I'll just answer the few questions. Yeah, you can share and then just show that.
Mr. Navneet, just allow me to share.
So meanwhile, till that comes up, why is MRI not a good modality for screening? So MRI as such is not an accepted or modality for diagnosis when it comes. The problem is the time that it takes. So when you have a screening tool and it is not practically feasible or replicable, remember, as I said, the principles of screening. Okay, a screening tool should be replicable, should be easy, should not cause, should be done with minimal thing. So an MRI of the thorax on an average would take about 30 to 45 minutes. Okay, and you should use MRI of the chest very religiously because the motion artifacts, all these things come into picture when you're actually doing an MRI. But a CT scan, which has got equal sensitivity, specificity, and of picking up even the low dose CT. We're not even talking about the normal CT that we're looking at. That is not. We're not even talking about the high resolution CT scan. We're actually talking about the low dose CT scan has got a very good sensitivity and specificity, and that is why MRI cannot be good for screening lung nodules. So I hope that answers your question. And then, is it right to add low dose CT in yearly health checkup in India with people with high risk factors of age and keeping in mind the false positive because of granulomatosis? How do we justify? Yes, the best way to go about majority. So if you have, there is a Canadian study which has actually looked at what you're talking is an opportunistic screening. As a person comes to you for either some other disease, point number one, or the person comes to you for he has a lung nodule, or for just as a regular health checkup, who has a high risk screening and you want to do a low dose CT. Yes, that is what is called as opportunistic screening, and there is evidence to show that opportunistic screening is one of has also reduced. There is no large randomized control trials. This all comes from retrospective. So there is one study from Canadian study which shows that it is helpful. So yes, it could be taken into consideration. How do we justify? Yes, we have to accept. We have to tell them that we India is where the incidence of the granulomatous disease is very high, and the possibilities of having a false positives is also high.
Is my screen visible, Prashant?
Yes, visible, sir.
So so when you look at solid lesions, you can see you define them as multiple and single and low risk and high risk, and then you decide. So when do we do a biopsy? You can see over here, any lesion which is more than 8 millimeters in size, directly goes for either a PET CT scan or a biopsy. And you can see if they are multiple, then you still follow up. So multiple lesions which are more than 5, multiple means more than 5, you consider them as less chance of being malignant. Whereas a single lesion which is more than 8 millimeters in size is currently the criteria according to the Freishner Society guidelines. There are other guidelines also, like the lung rats guidelines, but most often than not, it's the criteria is either 6 millimeter or a 8 millimeter cutoff. So when you look at subsolid nodules, because the growth, the doubling time is even longer, we usually serially follow up these patients for or longer, and show you the is longer, and unless it is growing serially over a period of time, or it has developed a new solid component, we usually just follow up these patients. And the size criteria for subsolid nodules is actually depending on the growth phase and the risk of the individual rather than the exact size.
Okay. Dr. Madhu actually pointed out a very important point, that which I actually deliberately kept it off, because the US task force has actually reduced it to 20 pack years. But most all the trials as of today still take 30 pack years, and to be on the safer side, if you want to have evidence based, both Nelson's as well as the NLST, both of them have took 30 pack years, and so 30 pack years would be. But for the US preventive task force has recently reduced it to 20 pack years. So that's it. And
is it right to add low dose CT in early health checkup in India?
Yeah, that we have just answered, Saruna. So if wedge resection for SPN yields a malignancy report and all the margins are free, then should we follow it up with a lobectomy or segmentectomy?
So I think things have changed. So currently, if most often in the Western, especially in United States and Europe, they would do a wedge resection for a patient with a growing nodule. And if it comes to be malignant, if the patient is lymph node negative, they will leave it at that. Whereas the Japanese, they are very particular that they would do an anatomic segmentectomy. And I think you have randomized evidence which has been published recently, two large randomized clinical trials comparing one comparing segmentectomy versus lobectomy for lung cancer, which has found that the survival is actually better if you do an anatomic segmentectomy for a patient with a lesion which is less than 2 centimeters in size. Whereas the second trial, which included wedge resection, also had a similar result. So I think, but the selection criteria are different. You should understand how each trial had gone. Currently, I think in our scenario, it's always safer to do in a fit patient to do a lobectomy for a patient with early lung cancer.
I think that brings to the end of all question and answers in the chat box as well as in the Q&A session. Mr. Nabni, Dr. Somshekhar sir is...
Thank you.
Yes.
Thank you, Prasanth Saravanan. And it answered more of it. This actually shows the quality of questions students are putting, how much their hunger for knowledge. And nobody other than you two can actually ever answer or understand this question. And I'm so proud and happy that our students' knowledge is going up with these talks and educations we are doing. Thank you very much, Prasanth Saravanan. And student, this is just the beginning. You're going to have this full month thoracic onco, and again we are revisiting a month later. So please hold it on, and this is not going to be repeated until next year. By the time either you're giving exam or a new batch would come. So thank you very much, Prasanth Saravanan. Awesome, superb, feeling so proud of both of you, and heartfelt thanks. All we can give from DNB is, I know there is a very, very nominal honorarium, but it is the blessings which we can give, which you carry to yourself and family. Thank you very much, both of you. Heartfelt thanks.
Thank you, sir. Thank you so much.
Sir.
Over to you, Navneet Singh.
Thank you. Thank you very much, trainees and faculty members, for joining.